Right, everybody, good afternoon. Welcome to the first Pan North East London CKD webinar. It's a great pleasure to be here. My name is Dr. Gavin Dreyer. I'm a consultant nephrologist at Barts Health, mostly based at Whips Cross Hospital. And together with Dr. Chris Carvalho, I'm going to be co-chairing this webinar. As is tradition, before we do a formal round of introductions, Joe, could we have the next slide, please? We're just going to go through a few basic housekeeping rules. We're recording this webinar. I hope that's all right with everybody. It's really important for us because we want to make it available later for future use. There's a huge amount of amazing content coming our way today. And we're really excited to put this together, and we'll let you know where and when you can access this offline. As per usual, if you're not speaking, please keep your mic off. It would be lovely to see some faces. Please keep your videos on if that is practical to achieve. Because we've got so many talks and lots to get through, I think what we'll probably do is take some Q&A at the end of the last talk, which is going to be John Robson's talk. But if you've got questions for speakers, by all means, put them in the chat and we'll do the hands up function later on. And right at the end, Joanna's going to do the honours by dropping a quick feedback form into the chat so we can learn how to do this better next time. Right, let's have a look at the agenda and I'll do some introductions. Joe, could you have the next slide, please? So I'm Gavin, as I mentioned, and I'm just going to hand over to Chris Carvalho to say a quick hello to our co-host. Hi, Chris.
Hi, everyone. My name is Chris Carvalho. I'm a GP in City and Hackney, and I'm also the NEL CKD co-clinical lead.
Great. And just before we go through the agenda, I'm going to hand over to our clinical director, Dr. Ravi Rajakaria, who's joining us from the Royal London, just to say a few words.
Hi, thank you very much, Gavin. I'm Ravi, the co-clinical lead for the renal network in NEL, as well as for renal at Barts. And obviously, virtual is pretty much standard within our department, and we obviously want to extend it to BHR, and Gavin is working with the BHR colleagues on that. Obviously, education is number one priority, both for GPs and patients, and this is a great start. Thank you, Gavin.
Thanks, Ravi. So Chris and I will start off with an update about CKD care in North East London. Where are we and where are we going? And then I'm really pleased that our Senior Service Delivery Manager, Famina Begum, is here, who's going to talk through some of the practicalities of the service. We're going to go on to some clinical content. We've got a pre-recorded talk from Dr. Kira McCafferty, who is the London Kidney Network CKD prevention lead, together with Linda Tarm, and they'll be giving us a rundown about why prevention of CKD is so important. And lastly, we're going to round up with a phenomenal talk from Dr. John Robson, who's working in the Queen Mary University of London Clinical Effectiveness Group. And John and his group have been supporting the virtual CKD service ever since its inception, and is a brand new tool to help us all look after patients with CKD better and more effectively in primary care. And John's going to talk us through that. But there's a lot to get through, so let's get started. Chris and I are going to sort of tag team in and out of some slides for the next 15 minutes. Remember, drop your questions in the chat and let's get going. So Joe, if we can have the next slide, please. Really, this is why we're here. I'm not going to read out these points, but it's been far too long since we've met as a network, as a group of primary and secondary care physicians and service managers. And it's really important that we've got the education program rolling again. We're here to talk about what's new in CKD care, how our service is running, where we think we stand in North East London, and particularly how John and his new active patient link tool are going to help transform the way we deliver kidney care. Next slide, please. You heard Ravi mention that education is really paramount for us. Education for ourselves as clinical colleagues, as allied health professionals, and also for our patients. And the pandemic really flattened this. And I'm the first to acknowledge, as a service lead, we've been too slow to pick this up. It's been important to get it right. There have been a number of pragmatic challenges on the way that I won't bore you with, but I'm really, really pleased we're here. And this webinar is going to be the first of a two-pronged approach for education of colleagues. The first is to have topic-focused and topic-specific Pan North East London webinars every other month. So there'll be one in June. We're going to rotate the dates, but it's probably going to be around lunchtime. And specifically of the 7 localities in North East London, we have got dates, I think, for almost all of them, for the renal team at Barts Health to join your protected teaching sessions to talk about CKD care, topic specific but locality based, with up-to-date data and case discussions as well. We remain open-minded about other options for CKD education moving forward. We've been piloting a new model in City and Hackney, which we can talk about next time. There's a lot going on, but if you want to feed back to us, there's an opportunity to do so in the chat later. Very happy to get emails from you. Please do drop us a line and let us know how you think we can iterate and improve. And the next slide, please, Gemma. Thank you. Chris, I think it's over to you for the background.
Thanks. I think it's important that we set the scene. We're here and what the work is that we're going to need to be doing for our population. And as we've come together as NEL, we're conscious that things are different across the patch, but also that things are developing and emerging as this is a growing and developing area. Next slide, please. So as I think you all know, working in the area, NEL is incredibly diverse, but it's also very fast growing. And some of the population that we're going to be looking at now is about the size of the increase is about the size of Croydon coming into the area in the next 20 years. But this is a largely young group that is coming into the area, but there are also not alongside that some aging groups, some different pockets of deprivation of different ethnic groups, and that comes into an area which is already under significant strain, that has already burning issues of kidney disease, of needs for dialysis, that is putting the strain on the services. If we go to the next slide, please, Joe. So this just really emphasises around the deprivation here that we've got, but I think it really tells a bigger story of the variation. And while that we consider ourselves now to be NEL is multiple different areas together, different needs, different workforces, different challenges. But there may be some consistency in the way that we work, and there is definitely learning that we can have from each other, and that's one of the aims that we'll have from these education sessions. If you go to the next slide, please. So there's going to be an increase, and there's a projected demand. There is a projected demand in activity in the inpatient setting. There's an increased demand in the outpatient setting, and particularly in dialysis. I won't go through that information there, but that really shows that this is something that we are conscious of in the ICB and within BART, that we are working very hard to try and identify, develop a strategy for, and hopefully manage. We go to the next slide, please. As part of that, one of the things that we had to develop were some indicators to help with prevention and management of patients who have CKD to help manage their risk factors. And these indicators were developed in response to the call for the LTC outcomes frameworks, and they build on some indicators that we have in different parts of NEL already, alongside what us as the experts working in this area think is reasonable to be asking primary care to be doing. And it covers a number of different areas, but by having these indicators, they help to focus our efforts into what we want to be targeting on and doing for our patients who have CKD, to help prevent or to help diagnose, to identify, to treat the different components, whether that's blood pressure or proteinuria, and to help manage the CVD events as well. And that focuses us down to the core aspects of the primary care management on CKD. Now, while this gives us something to work towards, it tells us what we need to do. It doesn't tell us the how. And while we can sit here and say on the webinars, you should be doing this, you should be doing that, this education program is going to be looking at how we work together to learn from each other and develop a program of education that helps us across the different workforces that we have and across the different areas to really manage CKD for the best of our residents. We go to the next slide, please. So this is something that is how we develop those key topics. And for me, the key things that we need to do is thinking about how we are doing our detection. And it includes the testing, the investigating, the coding of CKD. And then how for those patients we manage the blood pressure, we manage the proteinuria, and how we identify and manage diabetic kidney disease to help reduce the progression. There are some new drugs available like the SGLT2s, which are new to us in primary care. And there is some learning there about how we do the initiation, the management and the monitoring for a treatment that would have significant benefits. There's also the CV risk element, including the statins, but there's also a lot of learning that we can be doing through our data. And that forms the basis of the Apple CKD tool, the dashboards, the referral rates comparison, the health equity. Today is going to be a bit of a taster of these things. And this is going to be more of a program of works that will happen in the next months, in the next year, to dive into these in a bit more detail. There's more to unpick here. There's more to do. And there's learning, not just for our GP colleagues, not just for our nurses or our pharmacists, but the whole primary care workforce team. And alongside educating back up to secondary care as well. And one of the things that I think is really important for me as a GP is knowing what is expected of me to do, but of who I'm referring that patient onto. So who are the partners that I'm going to be working with? So when I refer a patient into Gavin, he has all the information that he needs, and he knows that that patient has been managed according to the latest best evidence, according to the best practice, that he's got all that information and is confident that when he guides us on what we need to do to help manage that patient, he knows that we are educated and informed on how to do that in the future. Next slide, please, Joe. So I say the audience is mainly focused on the primary care, the GPs, the practice nurses, the HAs, the pharmacists, and those R's roles as well. So your dietitians, your care coordinators, your social prescribers. So there's learning for primary care, but also for secondary care. And it's really important to emphasize this needs to go both ways. I can see there's quite a few people here today, and these are going to be expanding as we go through the year. And so with that, we would welcome other interested parties to be joining. So people who have an interest in CKD, in the management of that, in the learning of it as well, will be very welcome into these educational sessions, which will hopefully be discussion sessions as well. Next slide, please, Joe. Okay, I'm going to hand back over to Gavin.
Thanks, Chris. Really nice scene setting, and really important that we talk about some of the new innovations that are coming our way. A big one, not the only one, but a big one is the kidney failure risk equation. And Joe, if we could have the next slide, please. I've got a screen grab of the website of the kidney failure risk equation. And if you Google it, you'll find it, kidneyfailurerisk.co.uk. This is a real game changer. Previously, referral criteria and the management of CKD was typically based around the stage of CKD and or the EGFR, and certainly NICE guidelines reflected that. But the NICE guidelines have changed to include this incredibly valuable tool. What this does is it estimates for each individual patient the percentage chance of needing dialysis requiring kidney failure at either 2 years or 5 years. And it relies only on 4 variables: age, gender, serum creatinine, and urine ACR. The creatinine and ACR ideally should be as contemporaneous as possible, but I've been on discussion panels with this where if those blood tests and urine tests are within 6 to 12 months, that's pretty reasonable. And on this website, you can put those variables in the comfort of your surgery and identify the 2 and 5 year risk for the development of dialysis requiring CKD. It's a really, really informative tool. It lists all the referral criteria into secondary care. And I found it an invaluable method for helping me prognosticate with the patients I see in secondary care. And I hope you do as well. And if we could have the next slide, please, Joe, I'll explain a bit more. I've just got a grab here, and the next one, please, from the NICE website about what the referral criteria should be. And just highlighted in red is that key message from the kidney failure risk equation, which is that for any given patient, if a 5-year risk of needing renal replacement therapy is greater than 5%, we should certainly consider a referral for that patient. Now, again, what's really, really important here is the insight from primary care teams, because if you've got a patient who's 85 years old and is essentially housebound or in institutionalized care, and their 5-year risk of end-stage renal failure is 6%, then I would worry less about that patient than a 45-year-old who had a 5-year risk of kidney failure of, say, 10%. So knowing your patients and liaising with us and communicating to us how that risk fits into the bigger picture is absolutely vital. But I would really commend you to use the kidney failure risk equation. There's a lot of work going on at the national level to try to get this score embedded into both primary and secondary care records, I guess akin to how QRisk is used at the moment. So I would say watch this space. Right now you have to jump out to a separate website, but every time I do a CKD clinic, I've got that website open. I'm not going to labor the points because these are available on the NICE website, but here are the other referral criteria for you to think about in terms of accessing specialist opinions from us in secondary care. Let's have the next slide, please, Joe. What I've pulled out next is something about coding. There's been a huge amount of work from the London Kidney Network about the importance of coding for CKD. There's a document, if you haven't seen already, we can send round, and work that was done by my new consultant colleague, Adi O'Layton, in 2019, indicated that the odds ratio of being what we call a late presenter, or this other term, a crash lander onto dialysis services, that is making an emergency start to dialysis, the odds ratio, if you are not coded with CKD, is 8 times higher than if you are coded with CKD. So coding of CKD is so important. Look at the graphs here on the x-axis going back to 2016 right up to contemporaneous times. I'm sorry that the y-axis should have been percentages, but you can easily convert them. And you can see here in patches of East London where we've got the data from, how there have been dramatic improvements in Waltham Forest and Newham, for example. You can see the slight dip in coding around the pandemic time. That gap is when the data collection was being revisited and revised. But you can see there's a coding gap. There's a coding gap, for example, in City and Hackney, in patients without diabetes. 25% of patients with biochemical evidence of CKD do not have a diagnostic read code for CKD. And that's a really, really important gap for us all to work on and fill. And Kieran and Linda's guidelines from the London Kidney Network will be a huge help in achieving that. Let's have the next slide, please. I talked about giving you a sense of where we are with kidney care in East London. Here is some data looking at patients with CKD on a statin at the top. Again, that gap here, I explain why that is. Statin use seems to have dipped off since the pandemic and may be recovering, but slightly more telling are the two graphs down here looking at blood pressure control. Look at the graph on the right, first of all, CKD and a blood pressure target of less than 140/90. It was good, but not great. You can see that the pandemic really affected this, and it's not entirely clear whether this is an artifact of data collection, or the number of patients having blood pressure measurement. But the fact that the trend has increased makes me think these are probably real values. In the blood pressure control, really, I think dipped off, and certainly blood pressure management really dipped off during the pandemic. Go across to the left-hand panel. This is CKD and blood pressure control in patients who've got diabetes mellitus. And just take a look at the y-axis. Just take a look at the stark difference in the proportion of patients with CKD and diabetes in whom we achieve blood pressure control compared to those patients without diabetes. It's really, it's stunning. It's a stunning difference, and there's a lot of work to do and to think about in terms of prevention of risk in terms of this data that I've shown you here. And I think this is a challenge for all of us as we move forward. Let's have the next slide, please, Joanna. Thanks. I'd like to thank Isabel Dostel and the team at the Clinical Effectiveness Group, who've shown us some of that variation that Chris talked about. This data from 2020 to 2021, and it's the crude referral rates to the virtual CKD service per 1,000 population. On the x-axis is the primary care network list size. So these small blobs are all the networks in East London, and the referral rate going up on the y-axis. The blue line represents the mean. It's just over 1.4. But if you have a look at this, there's really quite significant variation in referral practice from networks where there's a 0.2 per 1,000 referral rate up to a 2.9 per 1,000 referral rate. Is this network up here a high-performing network where they've identified lots of CKD, they've referred all their cases, or equally are they perhaps struggling in this network and more reliant on secondary care opinions? I don't know. Down here, is this network disengaged from the process of CKD referrals, or are they really up to speed with managing their primary care work in terms of CKD and not needing to refer as much? I think that's an open question, but these differences in referral rate paint a picture about variation. And a lot of work has come out of the London Kidney Network we can share with you as well about variation in kidney care in North East London. Joe, let's have the last slide, please. Thank you. So our view from secondary care is the virtual CKD service is there to support you. We've got a bit of a backlog because of the junior doctor strike. I'm sorry about that. We are here to work with you, to walk the path together, to truly provide integrated kidney care for patients in primary care in East London. We want to hear about patients who've got chronic kidney disease who are not known to any other part of the renal service. So for patients already with a named nephrologist looking after them in clinic, our service would likely redirect you to that named consultant. But if you're looking after patients with CKD who we don't know about and you need help with their diagnosis and management, that's the group to refer. The virtual CKD service isn't a place for acute kidney injuries or those Friday afternoon phone calls of hyperkalemia nephrotic syndrome. For that, you need to call the on-call renal team at the Royal London Hospital. It's worth saying that not all cases of CKD need to be referred. There's no incentivization for referral at the moment, but that shouldn't stop you referring. We're here to provide specialist input for the cases where you've done the basic management, you've got the basic test, but you're still concerned that things are going in the wrong direction, or there's a particular quirk about the patient's care that you want our input in. The Barts Health Virtual Service, the Barts Health Kidney Team are here to help and support you. And I think with that, we're going to move on to Femina. Joe, let's have the next slide. I'll happily take some questions about this later. So Femina Begum is our absolutely brilliant service manager for virtual CKD. Femina and her colleagues, Farhat and Hassanul, are the ones who are doing the daily churn, providing you with the responses, managing the system, booking the appointments. And Femina's got some points to make about some of the technical aspects about referrals to our service. Thanks, Femina.
Hi, everyone. Sorry, I don't have a camera on my computer. So I just wanted to give you a bit of a background information with regards to the virtual CKD service we have here at Barts Health Trust. Joanna, do you mind going to the next slide? So I think it's very important to sort of understand that by virtual, we don't mean telephone or video. By virtual, it literally means there is no patient contact. It is just for the clinicians here in the hospital to review patients' medical records only. There is no patient contact, and it's really important when you are referring a patient to the virtual CKD service that the patients do understand the nature of this service and not to expect any update from our clinicians, because the GPs are updated via emails following the clinician review with regards to any outcomes or if there is anything that the GP needs to action on behalf of the clinicians. Then we also need to ensure that there are no appointment letters given to patients because there is, like I said, there is no patient contact from our side to the patients. On the next slide, so on EMIS, GPs, sorry, Joanna, you've gone too far. So this is just to explain the referral process with regards to referring a patient to VCKD. On EMIS, GPs must write referral questions into the care record and referral letter, and then select consent on the toolbar on EMIS, and then open up the CKD template and tick referral to community renal clinic. Now, the GPs do also have to do an ERS referral. So you follow the normal process that you would do when you are referring a patient to the hospital for any service, but you must ensure you select community kidney e-clinic. Now we do have four e-clinic services on ERS. So depending on which borough you do fall under, please make sure you select the relevant borough. And then you book the appointment via ERS, and on ERS they are booked on a Sunday. Again, patients need to be informed that the appointment that's booked, it's not an actual appointment, it's just something that we have on our system. So clinicians can review the record, and the referral can be sort of taken from ERS and uploaded onto EMIS. So on the next slide. And then once the ERS part has been done, the team will pick up the new referrals, which is done on a weekly basis, and then they will book the patients onto EMIS for our clinicians here in the hospital to review the patient's record. Clinicians do aim to do the review within 5 days of the appointment date. Now on EMIS, the team will be booking it onto a Monday because that's the date that will be sort of selected for the clinicians to review the patients from. Once the review has been done, the clinicians will update the admin team with regards to any actions that they need to do, be it discharge, follow-up, or a patient needs to be offered an appointment in the hospital. Any urgent patients are reviewed in the hot clinic. Again, that's given within like a couple of days from review. And then once the task has been completed by the admin team, they will also send a formal letter via EMIS to the GP. So the GP is updated with regards to the outcome, and then they can action and update the patient accordingly. I do have a web link here and the email address for the VCKD admin team if you do want to get in contact with them with regards to any patients that you have referred and are waiting updates.
Amina, thanks very much. It's really important, colleagues. If I could ask you to take that key message back to all the colleagues that you work with, that the patients would not expect contact from anybody in the clinical team at Barts Health and should not attend the hospital at any point when they're coming to their virtual appointment or engaging with the virtual process. It does happen from time to time. It's really distressing for the patients, some of whom have turned up on a Sunday morning expecting to see a kidney doctor, and we're as polite to them as we can, but we sadly have to turn them away because this is a truly non-patient facing service. There's a hand up from Chris just before we go on to Kieran and Linda. Chris?
Thanks. Just very, very quickly, I wanted to give to my experience as a jobbing GP of using the service, and it's just gives a really simple outline of what happens in the process. So I had a patient who had type 2 diabetes on insulin. They had their annual check, they had their blood test results came back, and it fell into my inbox. Their GFR had dropped. It was in the 40s, and it dropped down from just below 60, and their ACR had jumped up as well. Looking back, did all the relevant bits and pieces, but they needed then to get a input from the specialist. What do we do next? I sent the referral off. I went on leave. I came back, and in the notes there was a very clear plan, a well written up paragraph with actions for me as well. There are a couple of queries that I had, so I contacted the consultant, and he came back again, I think the same day, with an explanation, and that has enabled me to take the necessary steps to get them onto the ACE-ARB, to get them onto an SGLT2, and to get them retested and followed up. And that's just a really simple example of what happens in a few weeks in this service. And for me, it happens without that patient having to travel anywhere, without me having to do complex note trawling to write complicated letters and explain the history. It was a very, very good example of how we can do outpatients or expertise advice. So just in short, that's how the service works, and how we can really access the expertise and the input from our secondary care colleagues.
Yes, thanks. That's really nice to hear. I really do appreciate that. Look forward to hearing some of your experiences with the virtual CKD service moving on, but we've got content to get through, and Joanna's going to share with us a video made by Dr. Kieran McCafferty about prevention of CKD and its complications in the context of the London Kidney Network, and his colleague Linda Tan is going to be on hand to say a few words after that. Kieran and Linda, in my opinion, are doing national leading work, which we are incredibly proud of in London, to completely and utterly transform the way that CKD is identified, coded and prevented. So I think we'll hear from Kieran first, and then we'll hear from Linda.
Thank you very much. My name's Dr. Kieran McCafferty, a kidney doctor from Barts Health, East London, and I'm going to spend the next 10 or so minutes talking to you about identifying and optimising chronic kidney. So it is clear that the cardiovascular is a major priority, okay, and national audits have suggested to try and improve the treatment of cardiovascular disease in primary. What I would say is that one of the major drivers for cardiovascular across all areas of cardiovascular, from heart failure, coronary, patients are much higher with cardiovascular. Indeed, it is not just the GFR cardiovascular, but proteinuria is a key marker, preserve eGFR to in risk of cardiovascular. So we really need to try and identify with CKD early, aggressively manage the risk factors to prevent cardiovascular progressive CKD in central hemodialysis. More, I guess, bad news about CKD. CKD is unplanned admissions. So even early, even mild, there are numbers of increased admissions rise as progressive. CKD is a very expensive therapy. So if you look here at the national spend, a little bit out of date, but we spend a huge amount of money on looking after requiring dialysis, and perhaps not enough money trying to identify patients developing up on dialysis, such that, in 2009, 2010, we spent a third of the entire primary care budget on CKD on dialysis transport. We try and move money earlier pipeline. I suspect we might get better value. So this is where we set up London Kidney Network, specifically around how do we identify and prevent at risk of, or with early optimize their care, prevent them developing cardiovascular and reaching end-stage kidney disease. And also we're mindful that across London may be variation and another challenge. So what are the problems? Here we proteinuria as a major barrier. For people with diabetes, we're very good at doing blood tests for many areas. What we're not so good at doing, even in people with diabetes, which is probably most established, only just over half test. For those with high blood pressure, it's third. Who've got other risk factors, established cardiovascular, we hardly ever. We can't identify those people, and this really a huge gap in our patients may have already lost 40% of renal function before the time of our. So how are we doing this? This is all in line with, we want to try and prioritize risk factors. So we call it a kidney health. So anyone should have a kidney health, hypertension, cardiovascular, every 1 to 5 years. And this is for those people testing. If they have a no proteinuria, so urine, I'll be checking the GFR as part of their knee health check. And if their GFR is more than 60 and urinase, they are unlikely to have chronic. If their urine ACR 3 one-off, if their urine ACR is more than 70, it's a significant result. For all those people who've got an ACR, code their GFR according to their G stage. When we classify people as having chronic, to tell them they've got chronic, we know that perhaps 2/3 or 3/4 of patients with early stage don't even know that they've got, and how to do the things that we're asking, cut out salt, avoid NSAIDs, all the kind of things, hope that are kind of the bread and CKD man. If they don't know the chronic kidney, if the GFR is less than 60, failure risk equation, and lots of online for that, but that really helps us identify the precipitated referral. We should code patients, but based on GFR, correct GFR, and come on to, I guess, with a kind of to explain that they've got chronic, and then we should LKM. There have been a lot of guidelines. There's been a lot of new evidence, lots of new guidance, and so I can understand that for primary care and to try and make it as easy as possible. One of the important things I said is really coding. So we're looking not just and through an ACR.
I think we've inadvertently lost.
So, for example, patients no blood and urine test, kidney health check, their GFR is 7, so they would CK, and they are overall very low reserve. The reason we're obsessed with urine is very strong. People fairly advanced non have as high as the normal GFR. So we've now got someone for huge wealth evidence are progressive and dying. So our prevention works to really take patients with diabetic single cause, and also if you don't, we're really trying to make it easy for everyone to. And so what we've done, chronic kidney, and I've got heart, the heart failure with chronic signpost, and this really tells us how to do it. So getting patients on up to the therapy, start a statin, recheck, don't optimize, I would start maybe 50% on dose, and then next start an SGLT their blood. Fortunately for this again, start an ARB and max at an A and target, and that's similar with similar guide. And so we would hope that 3 months diagnose diabetic or proteinuria rasi on those. So we're very grateful across the spectrum. So that's a whistle-stop tour. Thank you very much.
Great. I'll pass on everybody's thanks to Kieran. That's a stunning talk. And I'm going to hand over to Linda, who works with Kieran in the London Kidney Network. Linda's a dietitian at Guy's and is very, very heavily involved in the London Kidney Network, does amazing work in terms of prevention. Linda, do you want to follow up from Kieran? And then we'll hear from John.
Gavin, for that lovely introduction. So as Kieran said, I co-chair the LKN CKD prevention work stream alongside Dr. Kieran McCafferty. And I'm just going to briefly discuss what we're doing to help support implementation of our pathways and coding guidelines across London. Because we know it's really important that whilst we have these amazing guidelines, if they're not used, if they're not understood by frontline clinicians, then the people who need to benefit from them, the patients, then yeah, it won't make any difference at all. So our pathways were actually produced over a year by primary and secondary care clinicians from across all of London, and that did include nephrologists, diabetologists and GPs. And the pathways were launched in September last year, and our coding guidelines were launched last month. Next slide, please. So since we've launched our LKN pathways last September, what we've actually been doing in the background is working with local teams and ICSs to help integrate our pathways into official CKD guidelines. So a big part of what we've done is collaborating closely with clinical groups and medicines optimization teams to help develop CKD guidelines that align with our pathways as much as possible. So that's to make sure that there's we don't create any confusion within primary care as well. We've also been supporting the process around primary care being able to initiate SGLT2s for CKD in primary care. So again, working really closely with medicines optimizations teams. And in terms of our project collaborations and partnerships, what we've actually done in Northwest London is we've actually established a formal year-long project with their academic health science network to help transform CKD care. And so our pathways were implemented into their ICS approved guidelines and into the GP systems as part of the support package for primary care. So you will find our pathways on several ICS clinical guideline websites, though the format will look slightly different, but based on each ICS's preference. We've held pan-London webinars and bespoke educational sessions with different professional groups, such as pharmacists and GPs, and lots of these online sessions were generally held at lunchtime clinical meetings or linked into existing teaching programs. And what we'd like to do, as Gavin said earlier, is to widen that remit so that lots of different frontline staff can attend, and that includes AHPs. We've also worked with ICSs to help set up and support local kidney networks, because what we do know is that really successful delivery comes from having local structures and local accountability. And in Northeast London, you may be aware that you've got the Northeast London CKD Prevention Working Group, which is led by Chris, and the LKN feeds into that to help support it. What we're also doing in the LKN is we're currently collating a package of CKD resources that could be adapted to create educational packages or support packages for primary care. So that package will include resources for clinicians and patients, and it will be available freely via the LKN website, which we hope will be going live next month. So just in summary, really, supporting implementation of our pathways is really a multi-pronged approach, and it's an ongoing process that needs close collaboration with local teams. So I just want to thank the NEL Training Hub for the opportunity to present today. Thanks, Gavin. Chris.
Linda, thank you. The work that we're focusing on is all about prevention, and as Linda said, there's a huge amount of activity and a huge amount of resource, and what we're going to hear from now, John Robson and his the Apple CKD tool really plays into that. So without further ado, it's a pleasure to introduce Dr. John Robson, who has been working with the Barts Health Virtual CKD service, supporting it, improving it in ways that I haven't even got time to list, but the work that John and his team have done has been absolutely instrumental. And John has given me a sort of an advanced demonstration of the CKD active patient link tool. It is absolutely sensational. So John, thanks very much. And just colleagues, a reminder, if you've got any questions, please do drop them in the chat. There'll be a feedback link soon. John, why don't you take us through to the end of the webinar? Thanks.
Can you see my slide all right, Gavin? Okay, so thanks very much, Gavin, and great to talk to you all. So this is the active patient link renal tool. CG's developed, as people probably know, other Apple tools. We did them for atrial fibrillation and also for statins in people with CVD. And I think they've really worked because they've been developed in conjunction with the secondary care physicians and teams from Barts and the wider kind of secondary care firmament, really. So we worked with Riaz Patel and with anticoagulation colleagues to develop the other teams, and this tool really builds on what was already developed by Sally Hull, my colleague, who's now retired, on her renal figure tool, but it takes it that step forward. And basically the problem I thought we were facing was that we were keeping being told there were different goalposts that we had to sort of achieve. You know, so the QOF would keep on moving, the DES IAF would keep on changing, local incentive schemes are all different, and so on. So I wanted really one tool that would kind of do all of these things flexibly enough and more. So that was the aim of this tool. And it was developed with Chris Carvalho, Gavin, Mike O'Hanlon, to look at the sort of safety elements of it. So and all the other people in the CEG team who helped make this possible. So so what it does, it is a search that's run in the practice. So it's a practice-facing tool, and that search is then imported into an Excel macro, which then displays the information in a really nice way and a flexible way that you can filter on different categories. And we have that tool, you're pleased to know, for both System 1 and EMIS, so it'll work in all practices, I think, across North East London and can be applied there. And what it does is it takes anybody who ever had their CKD of less than 60, most recent CKD was less than 60, or their urine ACR was greater than 3. So it's looking at anybody with potential kidney disease, and that's a large number. And the example I'll show you is in one practice. There's about 800 people in that practice. So that's a huge task. So you need to break that task down into manageable chunks. So it does that by filtering the lists into cohorts. So you might say, give me everybody who's got an EGFR of less than 45, or give me everybody who's got no urine ACR measured in the last 12 months, but their last EGFR was less than 30, or they've got diabetes, or they've got some other comorbidity. So it allows you to identify patients for follow-up for overdue measures who haven't had them done, or referral for serious deterioration. You can export a list of patients to send appointment messages, and I'll show you a bit more through Accurix or as a referral, and it improves CKD coding and treatment. So it allows a filter list, so it will show you all patients with that criteria, and then you can click on any of those particular patients to have an individual patient view that then shows you all the relevant data, including their meds, measurements, reviews, referrals, and in particular, as I say, it flags up critical falls in the EGFR. So you could select a combination of factors. So I could select people who have an latest EGFR less than 30, but they're not coded for CKD, or their ACR is missing, or they've got different comorbidities and they've got raised blood pressure or a raised ACR, or they're not on ACE, ARB, SGLT, or statins. So, and then, as I say, it gives a virtual review page after this filter. I'll show you the tool in a minute. So here is the tool showing you, I'll take you through the filters first of all. So you can see the filters, it says fall in EGFR. So it can show you everybody who had a fall of more than 10 points in the last 2 years between their highest and most recent EGFR. It could show you anybody in this cohort, as you know, they've all got chronic kidney disease because they've either got an EGFR of less than 60 or ACR greater than 3 or potential kidney disease. And you can see anybody who's never had that EGR repeated recently, or they've got no EGFR in 12 months. It's truncated a bit there, you can't get on the actual tool, you can see it. It can show you people who had no ACR taken or whose ACR is very high. It can show you these combinations of factors. So you could find everybody in the box who had a urine ACR of more than 30 and they had a blood pressure of more than 160, and it would list those people in that list below that you can see. So at the moment it's showing all patients in this practice. There are 800 of them. I've de-identified them, and you can see that they are ranked from the biggest fall in EGFR. So this first patient, their latest EGFR is 31. Their highest EGFR in the last 2 years was 90, so they've had a critical fall of 59 points in their EGFR. They haven't had their urine ACR measured. They're not coded with CKD, and they've got this rather low blood pressure, and they've got atrial fibrillation. You might want to know more about that patient. If I go down the list a bit more, there's somebody, patient 4, who has also got a fall of 36, and they have got CKD, they've got CVD, and they've got hypertension, and so on. So I can filter on all this. I haven't been able to do a live demonstration, but I'll show you the next sort of, I've selected, in this case, everybody who's got no EGFR measured within the last 12 months. And that gives me a count of 134 out of those 800 people. So I've narrowed down the scope. It's a bit more manageable now, and I can look at that. And this patient 38 is a 32-year-old female, and she had a fall of 17 in her EGFRs, and her latest value is 58. So you might want to kind of look and see what's going on there, and so on. If I take the next slide, I've chosen people who've got no EGFR in 12 months and their blood pressure is more than 160 over 100. And I've got 7 people in this list. And at top of the list, well, this particular patient here has, there's a patient number 646 has got a blood pressure of 189 over 114. This is an actual person. And so they've got an ACR of 13.6, and they haven't had any repeat EGFR. So you might want to look at that person. And if I clicked on that person, I could bring up I'll show you the page in a minute, the virtual review page. So here is the virtual review page of a particular patient. It's patient 646, that's what we'll be just looking at. And it shows at the top there basic demographic information, 43-year-old female, and that isn't her actual date of birth. I have to say that's a dummy date of birth. And the urine ACI 13.6, blood pressure shown there shows that she's got essential hypertension, not on any SGLT2 ACE or statin, and you can't see the bottom there. It should not be recently reviewed. Over on the right-hand side of the page, you can see at the top, I can export this entire page as a PDF. So I could attach it to a referral if I wanted to, which would give a nice summary for the consultant. I've got Kieran's nice, advisory guidance on coding, which is, as you know, quite complicated. And then I've got a series of hyperlinks, and I can click on the kidney failure risk score. At a single click, you can open it up and you can enter that yourself. We're not allowed as a tool without MHRA approval to actually put the calculation of the score into our tool, unfortunately. But hopefully at some point it might be incorporated into EMIS and they can do all that. And we also have got nice recommendations. So here is another example of the tool. And in this box here, you can see where there's more than one EGFR, then we can show the trend. And I think that if I just go on to the next one, oh no, I haven't got it here, but often it shows quite a nice, it shows up to 6 data points, and you can see the trend of people's EGFR, which gives you much more information if it's there than just a single value. And I think that's also very helpful. So it shows that this person's got a blood pressure of 169/99. They're on ramipril. They're known to have essential hypertension, and they're not coded with CKD. And it's showing that their most recent EGFR is now 55. So you might want to kind of look at this patient in a bit more detail with an actual review of their actual record and think about whether or not you need to take any further action. So lastly, the tool allows you to export the list of patients that you've generated either to Accurates, so that you can say, well, give me all the people who've not had their ACR measured in the last 12 months, with a particular criteria, and you could ask them to send a message saying, could you, get a urine test done with your GP, or you can export the list just to an Excel spreadsheet, or you can export a list of NHS numbers that you can, in fact, re-import back into the practice record if you wanted to display in the record a kind of grouping of patients. As I say, we can select the clinical system. We've got it for both ENIS Web and for System 1, so it kind of ticks all the boxes there. So I think it's quite a sort of a good tool, useful tool. I know that once we get it out there, people will say, well, can you tweak it a bit more? Can you do this? Can you do that? And what we'll do is, get back all the comments from people and probably, then have a revised version. And just one last thing to say is that because there was a change from CKD epi from MDRD measurements, we've got the old legacy values in there where there is an NDRV value, but it'll be showing CKD epi as that's now used by the labs. But and where they are different, we show it in red. So I'll stop there, Gavin, and we will have a user guide available online. We'll have CEG facilitator support, and CEG will be providing further webinars on the tool for anybody who hasn't been able to come to this one. So thanks very much,
John. Fantastic. I mean, the support you've given us in this new tool, it's really, really valuable. Thank you very much. When do you think we'll see a sort of a version of this being available to our colleagues?
I think it's going to be available hopefully this week or next. And we'll be emailing stuff out to practices, and the tool will be available to them so very shortly.
Fantastic. That's going to be hugely influential for advancing kidney care in North East London. Really, really appreciate that. Okay, colleagues, we've got 3 minutes left. There's a hand up from Chris. Chris, let's come to you. And just whilst we're hearing from Chris, if I can ask anyone who's got any other points or questions to drop them in the chat, I'll quickly go through some of the points in the chat as well. And Joanna, maybe you could please drop the feedback survey in the chat. So let's hear from Chris and then let's hear from Miriam. Thanks.
It was really just to answer Sophie's question about the previous falling EGFR tool, how easy and simple that was to use, and how to best use this. And John just mentioned that at the end, that there are going to be some further webinars that will go into this into more detail to help you to understand and use this as best. And just to emphasize that these are tools to help you for your needs. They have much more functionality that you may want to use or you may not want to use. And that was really the aim of developing this from the Trigger tool into the Apple CKD tool, to do the things that we need it to do more, to show more information and details to help to manage the individual patient and best optimize their condition. So there are things in there which will be more than you are previously used to using. And I appreciate that may be complex to understand. And so that's why it's important that we have the support from CEG facilitators and webinars to help guide you on to get the most out of this.
Thanks very much. And there's a question from Miriam.
Quick thing. I've been really impressed recently by the number of young people, Afro-Caribbean, who I think this is probably a result of remote consultations partly, who presented with very, very high blood pressures. They had no idea they hadn't had face-to-face new patient check, and also recently known about had patients with who'd had extremely high blood pressure, young, round about 40, Afro-Caribbean too, with brain hemorrhages and CKD4 as a result. Is there any way that we can spread around the word? Obviously, people know they should control their blood pressure, but particularly young people can get their blood pressure taken or be encouraged to buy machines. I mean, that was the first thing, because a lot of them said to me, well, I had no idea. I felt well. I didn't know I had high blood pressure.
Yeah, Miriam, thanks. I mean, I recognise that and reflect on it from my own practice at Whips Cross. We see a lot of unheralded presentations of young men who are Afro-Caribbean with exactly those problems. What do we do to improve community awareness? Well, it may actually be going into the communities themselves with peer leaders or religious leaders or patients who've been through the journey to share their experiences in that regard. Blood pressure monitors are I dare say relatively cheap at the moment for between 15 and 20 pounds in pharmacies. That's still beyond the reach of some of our patients. I wonder whether or not there's something to be said for asking our patients themselves to share the word among their friends and colleagues and families about the importance of blood pressure checking. This particular group of patients is an area of high focus in our southeast London geographic area, where colleagues of mine are planning to go into churches to teach and talk about blood pressure. But it's great. It's sad to hear that these patients are coming forward with such advanced disease, but it's really great to raise this. And I think it's a message for all of us that these patients are at very high risk. And I could go on about genetic variants, including but not limited to apolipoprotein L1, and how that increases the risk of high blood pressure in young patients. I've got Linda on the line. Linda, this is a really interesting point about prevention in high risk patients and communities. Did you want to add anything to that and answer Miriam's point?
No, I actually think you've covered it quite nicely, Gavin.
Okay, thanks, Miriam. Something for us all to think about and take away. I'm aware that it's just gone 2 o'clock and we've all got clinics and other commitments to go to. I'm going to stay online. You're welcome to stay with me. Just whilst I'm chatting away, we'll go through some of the questions. And Chris, if you're around, you can join us as well. Please fill in the survey. I can see Shahid, you got a hand up. Good afternoon.
Good afternoon. Gavin, you know me well enough, right? And so does Katie Bennett Richards. There are fundamentals that are going to just blow this apart. And the key thing is that, and I've actually ended up with people turning up to ambulatory care with this as well. If we can't get decent potassium or measure potassium, how the hell are we supposed to manage people in primary care? And this is an issue that I've raised over several times with the top brass of the ICB. I've gone directly to Ruth Ayling about this. What is so criminal that they could have somebody could have a sample spun down in different parts of NEL, so that at least when something gets to the lab, the result is reliable. I mean, to say, we've had people turn up in unscheduled care, and or the alternative is what unfortunately a lot of us colleagues in general practice are doing, is we're thinking, shall we take a clinical on this and say, well, actually this is probably artifact, so let's just forget about it. But there are people, most of us have issues about whether it is the real deal. Maybe they're diabetic, maybe they're hypertension, maybe they're on drugs that could actually genuinely put up their potassium. I mean, this is really so basic, and I really am frustrated why nobody seems to be tackling this. The second thing is that, look, I am a fan of all of it. I was really enthused by the Pan London Network issue about this, but the fundamental problem is there just isn't enough time. And however many tools or however many guidelines or things that you present, you need a pair of hands to follow through on all the patients that you identified on whatever apple that you end up. These people will, you will generate a list. It will sit in your reporting file on EMIS or in System 1, but you actually have to do something about it. And the danger is, you see, that these things will be up there, and GPs will be told, well, you were given the list, you needed to follow through on that. I sincerely want to. I want, this is part of quality improvements, my middle name. It's just, we don't have enough eyes to look at all these dashboards. We don't have enough hands or time to follow through on this. And believe me, in the next few weeks, as addressed in the next few weeks, we're going to have a monster of work put on us by the government, where everybody's supposed to be told and disposed of in primary care at the point whenever they ring at 8 in the morning. How am I actually going to be able to do all? The answer is enough. I'm happy to do it, but I just physically cannot do it anymore.
Thanks. Let me try and break this down one by one and go into the potassium issue. And Chris, I wonder if you can come in here, because you put something on the comments. We do get a lot of extra work in Whips Cross ambulatory care and A&E for the odd potassium which comes back high, which we think is spurious. And I would really like to see a community system where samples could be spun down to avoid this. It'd be a very interesting piece of work if we could somehow audit or collect this data. And Shahid, perhaps after this meeting, we could maybe plan that, you and I together, in a systematic fashion, maybe just focusing on the Whips Cross area, because through ambulatory care and A&E, there could be actually a good opportunity to get the data that might change the way we deliver this care. In terms of the workload for CKD, there's something here about the wider workforce and thinking about different cadres of healthcare, workers and teams who can deliver some of the changes that Linda, Kieran, myself and colleagues are recommending. And although this is not a panacea, the group of colleagues we're really working closely with to invest in and skill up is our physician associates. We have, I think, 4 or 5 fantastic renal physician associates at Barts Health. They are going to start to teach and train physician associates in primary care with regards to CKD. We need a little bit of funding and support to make that work, but it may well be that some of these bigger cohorts that John's tool could identify could potentially be looked after by a group of physician associates or prescribing pharmacists or advanced nurse practitioners. Now, there aren't enough of those. It's very easy for me to sort of list a different number of allied health professionals, but there aren't enough of those. We have been, I think, behind the curve with kidney care through no one's fault. The transformative work of the London Kidney Care Network, led by Kieran and Linda, is going to dramatically improve how we deliver kidney care. And there's a real sense that once we get patients on SGLT2 inhibitors, blood pressure control, statin, ACE inhibitors, the risk reduction in terms of cardiovascular events and unplanned care could be massive. So the short-term work which we're advocating, and there's a lot of it, believe me, I'm entirely sanguine about that, there's a lot of it. The short-term work that we're advocating, perhaps with the help of different classes of healthcare workers, may actually put us on the front foot rather than the back foot in terms of kidney care. Chris, Linda, any additional thoughts on that?
I think you've given us some good outlines of what we can be doing here. I think one of the things I'm conscious of in this webinar is that we've given a bit of a snapshot of some of the work that is happening and some of the things that are needing to go forward. Perhaps behind the scenes, we haven't explained some of the work that we are looking to do and looking to develop. And the good reason for that is that they aren't there ready to promote yet. But there is work that we are looking to do to promote, to reduce the workload in primary care as well as secondary care as well. And I am, as a jobbing GP, I'm very conscious that the constraints that we have in primary care and the limits that we have to provide the care that we want to for our patients. Part of that then is thinking about how we can make the work that we're doing as easy as possible to do the necessary things. And so here today, I think we've had a bit of a snapshot of some bits and pieces that are coming, but there is more work to be done. Certainly in terms of the work in looking at the high potassium results, I've had discussions in City and Hackney around this as well, and I know that they've started to understand what they could be doing from the lab side to help mitigate this, but that's a work in progress. But rest assured, I think what's important here is that we're having these discussions, and that between myself, Gavin, Ravi, and others, we are going to do our best to try and resolve this. And I can definitely hear the frustration that is there, that has resulted as a result of not being able to get anywhere. And I've noticed there's a mention of living in hope, and if there's a spare room in hope, I'd hope to move in there as well. But that's where hopefully I'd reside to try and resolve some of these issues. I'd like to discuss this more, and I think working with you, Shane, and Gavin as well to try and resolve these issues, I think is going to be crucial. Unfortunately, I've got to disappear off to another meeting, but thank you all, and thank you to Gavin, John, Kieran, Linda, and everyone else's contributions today. And I'm looking forward to the other future sessions.
Thanks, Chris. I'm going to just drop my email in the chat, which is always when my pulse rate goes up, but this is me. I'm here to be contacted. There's been some great points. If anybody wants to follow up, don't hesitate. I won't do sort of clinical work by email. Just the last point to make for Mina, our service administrator, asked me to point out that there are practices, I think, Shahid, including yours, that do not use EMIS in Waltham Forest. There are 5 practices. And as we expand our service into BHR, there are another 4 or 5 practices that don't use EMIS Web and unfortunately can't access the full benefit of the virtual CKD system, but can access kidney advice through Katie Bennett-Richards on the Advice and Guidance portal. And as you heard from John, can access the renal Apple tool, because it works across both EMIS and System 1, which is vital. Linda and Kieran's work, and Linda, I can see your hand up, also covers everybody, everyone, every practice in North East London and is not affected by which system you use. Linda, did you want to come in there?
I just wanted to make a comment about living in hope and the work that's going on behind the scenes, which we probably can't really get into now. But what is promising is that NHS England has prioritised preventative care planning in renal as one of the top priority pathways for the upcoming year in terms of transforming care. So that is going on in the background, and there'll probably be more information to come, but it's a bigger, wider discussion, and it's in its early stages of planning, but it's to go in the hope room. Thanks, Gavin.
Thanks, Linda. I think, colleagues, it's probably time to head off to our afternoon activities. My personal thanks to John, Linda, Kieran, Chris, Femina, and particularly to Joanna, who's put this all together. Sorry if I forgot anybody in the background, but we're really grateful to you all for coming. This is the first of many. We've broken the seal on our new education programme. I'm excited to see you all at the protected learning times in the different localities. There's a huge amount of work going on. We're walking this journey with you. It's a difficult journey and there are bumps in the roads, but we will get there. Thanks, everyone, and I wish you a good afternoon.
Thank you, everyone. Bye-bye.
Thank you, Gavin.